I am so happy to meet you in the program of JIP's Horse and Heart News. Yesterday, one patient walking into my chamber found to have exertional dyspnea with mild pedal edema. He had typical PND and orthopnea. So our provisional diagnosis, congestive heart failure. I couldn't make out S3 sound, but there was elevation of JVP. There are mild basal cryptations. So patient was subjected to ECG that shows mild ECG changes, but TROP-I turned out to be negative. Patient was subjected to echo, which revealed his EF is around 35%. Now, you have a patient who presented with features of cardiac failure with moderate LV dysfunction around 35%. Now, what are the drugs that are indicated in this patient? So, as I told you earlier, the mnemonic word would be SAC. SAC is always indicated for LV dysfunction. What is SAC? First S refers to SGLT2 inhibitor. Yes, this patient creatinine level is 0.8. So eGFR is very good, around 92. So we are able to add SGLT2 inhibitor. So patient was added dapagliflozin 10 mg. The small contraindication for DAPA is if eGFR is less than 20, the drug is contraindicated. So this patient had GFR around 92, so there is no contraindication. When you introduce SGLT2 inhibitor, since it causes polyuria, there will be mild hypotension, so you should be mindful about blood pressure. The patient blood pressure is somewhere around 140. So we were able to add SGLT2 inhibitor DAPA 10 mg very boldly. And another one is aldosterone antagonist. So I want to add aldactone, but only contraindication is hyperkalemia. Patient's potassium level is 4.3. When potassium is more than 4.8, the drug should be withheld. So this patient potassium is only 4.3. So the patient was added aldactone 25 mg. Apart from SGLT2 inhibitor. Then another one is SAC, C for carvedilol. Carvedilol starting dose is 3.125 mg. Morning off, night off can be added. But when the patient has good amount of crepitation and active heart failure, you can wait. So this patient has mild crepitations and mild tachypnea. So I don't want to add carvedilol very immediately, so I have withheld. Then another C is Sidmus or otherwise called ARNI. The ARNI contraindication is eGFR less than 30 ml. This patient GFR is around 92. So we have added ARNI, started with 50 mg morning off and night off. So another mindful factor for administration of ARNI is hyperkalemia. Again this patient is 4.3. So this patient deserved all the 4 molecules, but out of 4 molecules, since patient presented with active heart failure, we withheld carvedilol. Then we sincerely hope after administration of loop diuretics, furosemide and fluid restriction, once the fluid gets drained away from the lungs, then probably the next visit after 7 days, we have fervent hope we can add carvedilol 3.25 mg morning off, night off. So this is the way we can add these drugs to enhance LV function in the case of LV dysfunction. Thank you.